Thanks, Bob, and thanks for having me here today. So I guess as the neurosurgeon, I got assigned this topic, but I think that, a lot of the themes that that I'm going to discuss have been discussed today. As the last talk, well, I think it would be worthwhile to go through this and then maybe have some robust discussion. So I think we need to start with understanding what's the scope of the problem. And probably the easiest place to turn is large international registries. So as we look at the SRS, you see that from their early survey results, looking at 2012, 2017, we've got a neurologic deficit rate of under 1%. And we'll go through this in a bit. A more recent update from the SRS showed about the same, 0.7 to 0.94%. Now, we need to remember this is a survey study, right? And for those of you who are SRS members, you know that you basically are self-reporting. And so I think that Eric brought up a question of what is a complication. I think many of us, if we had a patient who woke up with paralysis, we would put that into the M&M database. A patient who woke up with a radiculopathy that resolved within a month, 3 months after surgery, I'm not sure that we would all self-report that. It is not delineated exactly what neurologic deficit is within this database. And we see that same thing come across as we look not only in the US. So as we look here in the UK, you see that there's the same type of effect of a total neurologic deficit risk hovering around 1%. We can even look at Japan and see that their neurologic deficit rate is going to be a little higher, again, because I think that there's slightly better definition. Looking at a motor loss or a sensory loss, again, I would ask whether or not the SRS members here in the room or in the audience would put a sensory loss as a neurologic deficit in the self-reporting, and I would say I would not. And so it's all a question of what are we actually counting and what do we care about. So the advantage of large institutional series is it theoretically gives a survey of the population. However, it does have its limitations. So then we can turn to, let's actually look in depth at single institution series. And we do see that there is a greater reporting here. If we look at this large series of from one Chinese institution, over 1,300 cases, you've got a 2% risk. And as expected, that was highest in revision cases. I think for the reasons that we've talked about today, that makes sense. We can look here within the US, and we've got a much higher neurologic deficit rate that might approach what I think many of us would perceive is real at 14%. Now, that's partly because we've included those types of neurologic deficits that may be more short-term or maybe more limited in their impact to the patient, including radiculopathy, including mental status changes. Again, I don't know that that's one that I would necessarily include. So to Eric's point, it's all about how you define the problem in terms of understanding what is the solution that you're going to be driving towards. Interestingly, in this study, they did not find that the risk complications of neurologic deficit was associated with the use of osteotomies, and we'll talk about that a little bit later. And looking here at a much larger series, 285 patients with 2-year follow-up, you see that there is an initial deficit rate of 10%, but that was only permanent in about 4% of patients. And I think that, in this case, one of the interesting findings was that this was also related to the patient's functional status preoperatively. And I think that this is something we'll see as we look at neuromonitoring. Patients who come to us with a deficit are more likely to have a deficit that is worsened or permanent over time. So as we think about this scope of the problem, now looking at what I think is one of the best publications out there trying to assess this is the Scully risk study. And there's results from the initial study and then a bunch of subgroup analyses. But looking at this component, which I thought was very intriguing as we think about these types of registries, is breaking this Scully risk population into those patients in whom the data was retrospectively collected versus prospectively collected. You saw a significant difference in the outcome and reporting. So with the prospectively collected patients, the risk of a neurologic deficit, and it did include, in terms of spinal cord, nerve root, et cetera, was about about double the risk of that recorded in the retrospective population. And so I think that the initiatives, Eric, that you were describing in terms of a really detailed system that is highly accurate, it does not seem especially onerous in terms of collection, really is probably where we need to go in terms of having some means of prospective data collection that we all can look at. Because I know if I think about the patients in whom I have had some deficit, I mean, it may show up in one note on a postoperative note. You know, a patient has some slight weakness in ankle dorsiflexion and never be reported on again. And so I'm not sure in this retrospective analysis how much that would be pulled out. And then we come to the question that, you know, we've been talking about today, which is how much does all of this matter? We want to achieve perfection, and yet we all define perfection in slightly different ways. You know, I think patients often ask me, how successful is this operation? To which my response is, well, how do you define success? You know, I mean, if you define success as I have no problems, no pain, well, then this is a very unsuccessful operation. If you define it merely as I'm better than I was and it was worth going through all of it, sure, then we may be achieving success in this case. And so we know that the health-related quality outcome measures do not always correlate with this, and I think, Eric, you brought this up as well, that, you know, we do see that there are effects on the SRS-22 in terms of function, pain, self-image, et cetera, with neurologic deficit, but interestingly, the satisfaction was equivalent between these groups. And so, you know, as you survey the literature, what you see is that there's a disconcordance between radiographic outcomes, health-related quality of life, and patient satisfaction. So that patients, and we've all probably had these patients who are our personal albatrosses because we feel that we have done wrong by the patient in terms of the outcome was not what we would have liked, and yet the patient is still satisfied with the outcome. And vice versa, we can have situations in which radiographs look perfect, functional improvement is great, and yet patient is dissatisfied for reasons that we can't exactly pin down. And so I think there's probably something to the psychological makeup of patients as they head into surgery and understanding what their expectations are versus what we are able to provide as surgeons. And we know that this does have some change over time, right? As Eric alluded to, neurologic problems tend to improve. And so you can see that as you've got those with a greater injury at discharge, they are going to have overall less recovery, yet they will have some improvement. And I think for many patients, it is really a question of what their trajectory is over time. So if they see that they are improving overall, they are going to be more satisfied than if they've hit that plateau. And I think we only need to look at what I think is sometimes some of the most challenging patients in terms of our cervical myelopathy patients, where we are typically operating to prevent worsening. And I always tell patients, if a year after surgery you're exactly the same as you were the day I operated on you, that is success for me, and yet it will not feel like success for you. Because you will have to mentally realize that you were going to worsen and you have not. But that is much harder conceptually for people to grasp. So as we think about this, however, there is some data to suggest that this really can have some difference in terms of these outcome measures. And I think this goes to a lot of the discussion we've had today in terms of what is our target, what is our goal. If we are trying to have patients be satisfied with the outcome of surgery, we may need to have a different intervention than do we want them to be purely functional after surgery versus are we looking at pain measures. And I think understanding those targets preoperatively is critical in terms of assessing how successful we are. And I think part of the difficulty we face is our inability, due to lack of very organized registries, both internally within us as surgeons and then institutionally from hospital or healthcare systems perspectives, we are forced to gather data retrospectively. And so we are post hoc defining targets rather than heading into it prospectively gathering data. So let's think about some of these neurologic deficit causing issues, right? So I think that osteotomies are a fairly significant surgical intervention in the adult population that I think any surgeon would say clearly increases my risk of causing some sort of neurologic deficit. And we can see that looking at this 5-year study from the British Scoliosis Society, looking at the number of cases that a surgeon has done, you clearly see that there is a reduction in the overall neurologic complication rate. So this brings up the issue that Cal Kabesh brought up earlier, and in fact, here's the slide from his study demonstrating the learning curve of osteotomies. We are forced, as the discussion from that presentation brought up, how are we actually going to address this issue? Cal mentioned, he operates as a single surgeon, potentially with a fellow. Clearly here in Seattle at Virginia Mason, we do use a dual surgeon approach. I know others in the area do as well. And, I think that Chris Ames and Vedat Devran down at UCSF really initially pioneered this. In their case, as in ours, it did happen to be neurosurgeon, orthopedic surgeon working together. And I think they saw a significant reduction in complication risk, and specifically included within this a risk of neurologic deficit. Looking at meta-analyses of single versus dual surgeon studies, you see that if I pulled out here just the neurologic deficit risk, and you see that overall every single one of these, except for the very top one, every single one of these favors the dual surgeon approach. These are not wildly dramatic. This isn't a 15 times fold reduction, but it is a significant reduction in the risk of neurologic deficit with dual surgeon. I think there's many issues that come into play here. We've talked about when neuromonitoring changes happen, taking your own pulse first. I think that is often easiest when there's someone else in the room. I find that personally, if I am the primary surgeon versus my co-surgeon, we have a different relationship to the patient. We have a different understanding of what this patient's goals are, and sometimes as the primary surgeon, you are more able to say, you know what, they would be perfectly happy with where we are right now, versus saying, I really don't want to cause this woman any harm, and someone else going, I think we're okay to keep going, and I think that interplay, I believe, really is able to lead to appropriate discussion in times of stress. But again, I know that there is some argument against it, that as surgeons, we should be able to charge forward and have fully within our control everything that we need to solve the problem. I would just say I'm human and acknowledge that. So the question becomes, does monitoring help? Yes, as long as we agree that it has its limitations. So if we think about it, if we focus here on the monitoring specificity and sensitivity, it does appear that the combination of motor evoked potentials and somatosensory evoked potentials in deformity surgery has a benefit in terms of identifying spinal cord injury. Right, and I want to qualify it as such. And we see that is played out across multiple studies, that SSEPs on their own are not all that great. MEPs are much more predictive of some sort of actual change, and the combination of the two may actually, as an interplay, provide some benefit. So looking at how does this play out overall, well, if we start off with patients who don't have data, what are you going to do, or how are you going to counsel them? So looking at this large series of 4,300 cases, so 58, so about 2% or 1.5% had absent SSEPs and MEPs to begin with. And you saw that those patients had a much higher risk of some sort of postoperative neurologic deficit. Now, many of us would argue, well, that was already evidence of an injured spinal cord, regardless of what I as a surgeon did. But I do think that these are patients in whom it is probably worth, now obviously you only discover this after they're asleep, but I think that if you're looking at a patient who already has significant spinal cord compression related to thoracic disc herniation, cervical myelopathy, et cetera, those are patients in whom it is probably worthwhile counseling them that their risk of a postoperative deficit is much higher. And so I want to bring up this Stagnera wake-up test as we get to the end here, but the recommendation from this study was to consider a wake-up test in those patients. We can see that this same type of thing holds up in patients preoperatively who are myelopathic. So you have, in this case, preoperative myelopathic patients undergoing VCR with absent SSEPs and MEPs. 1/5 of these had post-op neurologic deficit versus 0% neurologic deficit in those who did not have myelopathic symptoms before surgery. Again, recommendation, consideration of Stagnaro wake-up test, which we'll get to at the end. So as we think about all of this data and realizing, that the SRS is a selective body for, providers who have an interest in research and do adult deformity and pediatric deformity surgery, but taking that as a whole, looking at some of the surveys that have come out of this, a graph on the left is what is the preferred method of intraoperative neuromonitoring, and that included SSEPs and MEPs for most surgeons. And as we think about, in this case, when there's a significant decrease or loss of motor function, do you start steroids, right? I will say that in the neurosurgery literature, steroids for spinal cord injury has had a very patchy history. I think it is a knee-jerk response from many of us, partly based on legal consideration rather than good scientific data. However, as you look at this, you see that there's a fair percentage of people, which is the upper, the right, and the bottom graph on the left, so well over 75% are going to use some measure of steroids. So probably less than a quarter are not administering any steroids. I'm not sitting here telling you should or shouldn't use steroids, because again, I think that the data is very equivocal. Just to say that you do need to start to wonder at what point are you going against what the bulk of the cohort is doing, even if there's not great data for it. And on the right, do you use a standardized protocol or checklist? And I think that, we'll look at the Vitale checklist published in 2014 in just a little bit. That's the 50% utilize that version of a checklist. I do think that this is one of those circumstances where it is highly beneficial to actually have a checklist up in the room that people can follow in the heat of battle, especially if, as many of us are in teaching institutions, and so we may have, although we ourselves are present for each operation, some of the other team members may rotate around. This is the statement from the SRS, and I just want to read this because I do think it's appropriate when we start thinking about, sorry, I'm of course on call and getting paged. I'll deal with that in a moment. The Scoliosis Research Society concludes that the use of intraoperative spinal cord neurophysiologic monitoring during operative procedures that aim to correct spinal deformities is considered the standard of care when the spinal cord is at risk. So, you want to think about the fact that for a deformity operation, primarily in the thoracic spine, I would argue, premier body is saying that this is indeed the standard of care. Now, it does not tell you what to do when you don't have monitoring to begin with or when the monitoring drops out, but I do think that you really need to consider under what circumstances are you willing to proceed with no monitoring present. And they argue that this can provide for early detection of an evolving or impending spinal cord deficit that will allow timely intervention. So as we think about that sort of detection and intervention, this consensus statement really looks at the patient factors, who are the high-risk types of patients. And these next few studies, this one from 22 out of spinal deformity and the next one, the Vitale one, I think are really critical to sort of look at and have present in your mind or in the operating room. So we think about what are the patient factors that come into play. We talked a bit about myelopathy, skeletal dysplasia. We talked about pediatric surgery and some of the difficulties that they have in terms of spinal cord dysfunction. The curve and cord factors, there's a lot of work looking at the apex of the curve, how much is the spinal cord deviated off the midline, consideration of implants at those apical levels, and then surgical factors as well. And when we think about this best practices Vitale study, I think that this is really breaks it down very nicely in terms of the interventions that include, on the left there, we've got the gain control of room. I think that is critical. This is when the music goes off. There's a discussion discussion with anesthesia, discussion with neuromonitoring, anesthetics and systemic issues that are at play. What is the most recent blood pressure, anesthesia setup right now? You can go through the technical, and then the surgical. I think from our standpoint as surgeons, we really think about, what did I just do that I can undo? Do I need to remove implants? Do I need to remove rods? So I need to undo correction. And do I need to think about getting some sort of imaging, whether that's fluoroscopy, ORM, et cetera? And I think that the wake-up test is also listed on here. Post-operatively, I think Eric said it nicely. He doesn't want to know about the deficit at the end, but I do think that this study, this was a high volume of patients looking at just a simple, at the end of surgery, what is my quick and dirty? I might be able to go home. The monitoring did not change or did change slightly during the case. Can I go home feeling like things are relatively safe? And overall, if the ankle dorsiflexion was full, essentially every single one of those patients was neuro intact. And if it was weak or absent, that's when you ended up with patients who had an immediate or post-operative delayed onset. So, I think it's sometimes difficult for some of these cases to awaken patients after surgery, more limited, but the simple wiggle your toes back and forth, move your feet back and forth is probably going to give you a pretty good assessment, at least this study would suggest. So as we think about points for discussion in the discussion area here, the Stagnaro wake-up test, my question is how, as we look at, most of us in the room here have gray hair, and we are going to be the aging out population of surgeons. And as we think about the younger group of surgeons, how many of us do a wake-up test enough to have the next generation really know how to do it? And that's not only on the surgeon side, that's also on anesthesia side. So I would love to hear your guys' thoughts on how often you actually do this and its role. I think that this really came out of pediatric scoliosis surgery in a pre-monitoring era. And I'm just not sure how much it's reasonable in today's world. And then second, as we think about osteotomy levels, we heard about cervical osteotomies and thinking about our upper thoracic, keeping it on the lower side, T2, T3, et cetera. And as we think about lumbar, there's an argument that's been made for driving our lumbar osteotomies towards L5, given that the root deficit that you will have there may include only a plantar flexion weakness rather than, as we think about putting it at L4, I don't think many of us do it at L3, but if you were to, that you start heading up into more proximal weakness that may be more debilitating for a patient. All right, thank you.
Great talk. Really good talk and really a great conclusion to the whole seminar. Monitoring, my impression in my own OR is that the sensitivity of our monitoring has become higher over time. And I feel like I'm seeing more what I'm going to call false positives. And that also becomes a risk at surgery that we may pursue or change. I had a case just recently that I was planning a 2-level total disc. We had a monitoring change at the 2nd level, and I changed the plan to an intraoperative fusion because I wanted to stabilize the segment if it was causing it. And I revised my decompression, which sort of took away enough end plate that I didn't think I could do a total disc there safely. So bad intraoperative decision, and then the patient woke up normal. And by the time we closed, the MEPs were back to normal. So I'm wondering, is there any data to suggest, or is there any cause to believe that the systems we use are getting sort of hypersensitive?
I'm going to turn it over to Eric or Doug since I had to step out to answer the call. But I would say, I do think that it does seem that there is some improvement in neuromonitoring in terms of our understanding. I'm not sure that there's a point at which extra sensitivity may be actually working against us, and I think we only need to look at, there are people who monitor every discectomy, and I'm just not sure how relevant that ends up being.
Yeah, I think that there's something to that, and a lot of it is your anesthesia and how well your anesthesia team works with you, how used to this type of anesthetic they are. I think we've gone, can I use that? For the first 10 years that I did motor evoked potentials, we still used gas. And we used some gas and we used some ketamine and now we've pretty much gone to TIVAs for all of them. And I think that the rate of not being able to get motors has gone down. It's very rare. And now I'm not doing the kind of crazy cases that we see Cal doing or Oheneba, where probably Kleinberg, where you've got some super weird kyphoscoliosis and a cord's draped, and the kid walks in or the adult walks in, but that cord is really bad, and maybe they don't have motors. So, but the one thing I'll say with the TIVAs is, you will see this kind of slow decline in your MEPs over the course of a long case that isn't necessarily an abnormality, but it's not a precipitous decline. And but I've also seen kind of a slow decline that kept going as we were waking them up. And actually, it was a growing rod case that I did, and we were closing, and we keep doing motors until the fascia is closed, and there was sort of this little drop, and we're closing, and then we kept checking it, and finally, we had a real drop in our motors, and then our SSEPs dropped, and that's when we go through our checklist, and I went in and I let up on some of the correction and waited and things came back. So you need to believe them, but you're right that they are more sensitive. And I'll comment on the Stagnara wake-up test. I'm old enough to remember when we did it, and we did it every case because we didn't have motor evoked potentials. We had SSEPs, and we didn't really trust SSEPs that much. And so we would have a conversation with the patient. We're going to wake you up. You're going to hear people yelling at you. Here's what we want you to do. This was a whole preoperative discussion. But also, we were using gas, and you can turn it off, and they wake up pretty fast. If you're using propofol, are you going to wait an hour intraoperatively for them to wake up? I just don't think it's very realistic to think that that's going to be effective. And the other thing that I'll say is, and that was the Bridwell paper was from '05, so it was a few years ago that they're advocating that. But when are you going to do it? You don't know when they go bad. Cal showed that case where he really wasn't doing much in that kyphoscoliosis case, and his motors dropped. Well, when is the right time to do it? You don't know. And so, I think that if you don't have any motors in those high-risk cases, I don't have those cases, but I don't know that I might just wake them up, because I think you've got a real chance of hurting them, and you have no idea when you did it.
Yeah.
It's complicated. You want to?
I'll just do just a quick comment. So I agree with a lot of that. So I think the good news is most of the time, if they're going to have bad signals ahead of time, you know it. It's a sick cord, the MRI looks terrible, it's some awful kyphoscoliosis, in which case then you can prep the patients ahead of time for how to do a Stagnara, because wiggling the toes is not actually what you want. You want the ankles to move up and down, and so I'll kind of go through that with a child or with the adult if we have to go ahead of time. There's sometimes some weird diseases. CMT is a classic one where you get poor signals. And so for those kids, if they're neurologically normal and I'm doing an AIS type of operation, then I'll tell them, hey, listen, this is what we need to do so we can get reliable stuff on you. I think if you don't have signals and all you have is a Stagnara, then we do it the way that you used to do it back in the day. You put them to sleep, and you do your exposure, you got a wake-up test. Place your implants, wake-up test, correction, wake-up test, prior to fascial closure, wake-up test. And so it's painful, it takes a hell of a lot longer, but I agree with you, the answer is that you want to make sure you do no harm. If you can't do that reliably in your institution, or you're not, then I agree with you wholeheartedly, the answer is don't do the surgery, you can't proceed. I do think that, and I want to just clarify, I examine all my patients in the OR before they leave to make sure that they're have normal neurologic function. I think the thing that I find disappointing is when I don't know, when they get no signal abnormalities, and I end up with then some weakness afterwards. It almost always is L5. It's rarely anything else, and so it's just a very difficult nerve to check. What I've done over time is I trust me. And so I will inspect those nerves, particularly after like an osteotomy. And if the nerve feels tight or there's some tension to it, but I take a little more pressure off of it, that seems to, I feel like my neurologic injury rate has gone down with time, but I don't know how you teach that. I think you just have to see a bunch of them, which is really tough. But I would love to, I feel like we should have that better. I just don't understand the nerve is functional or not functional. It seems to me that we ought to be able to monitor that better and monitor these high-grade spondies and really understand if we are or are not putting that nerve under such undue stress that it can't function normally. That just seems to be something that we should have a better handle on.
Well, I know one last thing I would acknowledge is there is wide variability in terms of what cases get monitoring based on surgical preference. And I know the data within Providence, and there are surgeons who use it very infrequently, even in cervical cases, and then there are surgeons who use it in every lumbar case in addition to thoracic and cervical. So I haven't done a Stagnaro wake-up test since I finished training, I will say. So I agree with the statement of the SRS in regard to the need for monitoring as a standard of care. They didn't say that you need to do a wake-up test, so I don't think that's considered standard.
It has been generally quoted as the definitive end test, and I think it's fine to say, yes, we can do that, but if you haven't done one since finishing residency, and I've probably done it once or twice, I'm not sure how reliable it's going to be in the middle of surgery suddenly to go, anesthesia, I need you to wake this patient up.
The good news, though, is typically what's happened is as they lighten the anesthesia, the motors come right back. And so it's almost an over-anesthetic problem. And as you do that, and the only other thing, too, I'd say, and then I really won't be quiet, I promise, is that if you have a motor evoked potential deficit during surgery, that doesn't mean the patient's paralyzed. It's an indication that something has happened and you have the opportunity to fix it. I think Larry actually speaks about this very eloquently, and he says that is your opportunity to really be a surgeon and be a doctor and to work the problem.
Yeah. Last thing I'll say about the Stagnaro wake-up test was it was always the R2's, the junior residents' duty to get down under the drapes and scream at the patient, and so you guys should be thankful that that's kind of gone to the wayside.